USA podcast number 13. Today, Dr. Bonner and I are going to be talking about when it is time for our patients to see a surgeon, when you know that it might be time for you to sit down with a surgeon to discuss the possibility of a surgery. Today, we're probably going to focus primarily on the spine and more specifically the lumbar spine. Um, this is an interesting area because I'm sure, Dr. Bonner, you see a lot of patients every day. Some either have already seen a surgeon before they saw you, or you know you've been treating them for a while and they may end up going on to see a surgeon. But it's always interesting, uh, depending on the region of the country we're in or patients are in, there seems to be a tendency maybe to be referred to surgeons sooner rather than later, or almost to surgeons as the primary uh, physician to initially evaluate patients for certain conditions, or vice versa. So, um, with that being said, um, you know, what's your experience, at least in the region of the country where you're at?
Um, I think a lot of times it also can depend on the primary care physician. Some of the primary care physicians may be more likely to send to a surgeon as opposed to a non-surgical person. And then I think one of the other things is I think a lot of times the patient kind of ends up choosing who they want to see. And I think that's kind of been borne out in a study or two. But some people tend to think that surgery is the answer for every problem they have. And so those people will find a surgeon and get a surgery if there's a surgery to be done. And so there's some people that just, um, look a lot of times when we're treating these issues that might have a surgery available to treat them. A lot of times it may take some time to get better with some of the treatments that we offer. And some patients don't have the patience for that. And so sometimes they kind of end up just getting to a surgeon on their own because they want something done sooner rather than later, and they think surgery is going to be the quick fix. Those people might end up trying to convince them that there's other options, but some people just have the personality type where they'll just go seek out a surgeon and get a surgery done. So those would be the other things I think I see that kind of influence that. Definitely, I work a lot with different primary care physicians, and so I see different referral patterns based on the primary care physicians. There's some who send all of their patients with musculoskeletal issues or painful issues directly to me first as the first consultation. There's some who send them to me and send them to an orthopedic surgeon at the same time, like both consults in at the same time for orthopedic issues, musculoskeletal issues. And there's some who refer mostly to surgeons, and that's maybe based on preference or training, or maybe they know the surgeon and know the surgeon takes good care of the patients. So it could be like a personal thing too. But so that's some of the things that I've noted kind of in my practice a bit. I don't know. What do you think?
Yeah, I would agree with that, and I'd probably add, years prior, when medicine was a little different, uh, you know, you had the family doc and you had surgeons, right? I mean, there might not have been a lot of other subspecialists that can take care of a lot of these issues. For instance, physiatrist or PM&R specialists, and especially PM&R specialists that have gone on to do pain medicine or spine fellowships and training, really have now kind of moved into that area where most, I think, surgeons would initially see patients. So, years ago, maybe 20, 30 years ago, that wasn't obviously that common. So they would see the surgeon as the next go-to. Surgeons would probably work things up, maybe treat a little differently than now, right? When you see a surgeon now, it's primarily, okay, do you need surgery? Yes, no. If not, okay, I can't help you. you have to go see someone else. So I think it's just the way healthcare is delivered has changed as well. And probably some people who are maybe used to the previous pattern of delivery or referrals, might kind of tend to do that as well.
Yeah, I
Um,
would definitely agree with you there. I've definitely seen, some of the younger primary care physicians who maybe know more about our specialty are more likely to kind of refer the patients over and kind of understand how we're going to treat them, as opposed to some of the kind of older classical physicians, kind of they're referring more to an orthopedic surgeon or a neurosurgery spine surgeon for a lot of the spine issues, just because, like you said, that's kind of the way it used to be. They were the family doctor and they would, send them to the surgeon if there was a problem that they couldn't fix. So I've
it,
definitely seen that a lot.
yeah, and it's important to note. I mean, the way healthcare has changed, you know, obviously we're coming in sort of on the tail end of one transition, but there's a lot of new changes occurring with healthcare every day that we experience. But uh, you think about physicians in the past may have had more time to spend with patients, especially now. These are large health systems. There may not be quotas, but there are, you're expected to see a certain number of patients. And to be able to kind of, justify your means or your necessity, you have to do what you're trained to do.
Yeah.
And, so surgeons, they operate. If they see up front that, okay, this is a brand new issue or this isn't surgical, I think if in you might end up, you know, okay, kind of getting pushed along to the next person. You end up spending more money. You have another copay. Deductibles are higher, so you end up spending more money as a patient as well to try to get the care and especially the education you need in the
Yeah.
beginning.
Yeah. At a previous hospital that I was working at, they had a call center and patients would call in and say, "Oh, I have back pain." And they would say, there was like an algorithm and they would say, "Okay, do you want to see a surgeon or a non-surgeon?" And the patient doesn't know if they have a surgical issue or not. And so, they would just say, "Oh, one of the two." And if, sometimes they might come see us and they really need surgery, and sometimes they might go see the surgeon and not need surgery at all. And so, um, it was just kind of like what you're saying. Like there's just, sometimes there's extra consultations and extra expenses that maybe aren't necessary if, um, maybe there's a better system in between there to kind of educate people and let them know what they should be doing. But it's hard sometimes, definitely.
Yeah. Hence telemedicine,
There
us,
you go.
right?
There you go.
I think we're a good resource for that. But to try kind of transition now into some of those conditions, well, um, like you said, a lot of spine related issues, there is more than one way to treat the issue, whether conservative or surgical. So, so again, you have, for instance, a disc herniation that's touching a nerve. You have classic radicular pain, which we've talked about on other podcasts, and you see a surgeon first. Now, most surgeons, especially a lot of the surgeons that are more recently trained, you know, most of them will go down maximize conservative care. But some surgeons, okay, you have a lot of pain, you have the disc, you might be a little weak because there's some pain inhibition. Um, we could operate to fix that, right? So, or you go to a non-surgical specialist, PT, possible injection once you've kind of in medication adjustments and some time. And you could have very similar outcomes. One, you might get a little quicker to the same outcome one way or the other, but two totally different paths, similar outcomes. But I would argue long term, there can be some big differences.
Yeah. So who do you definitely send to surgery? Like sooner rather than later?
Well, so if I'm seeing a patient, they've seen their family doc, and then me, say it's for a disc herniation, right? So we'll talk about that first. Patients who have an acute disc herniation with, or like, so symptoms are relatively recent, maybe a couple weeks. Maybe the symptoms have escalated, so the pain is getting worse, but they have either significant weakness. So typically we'll think of like a drop foot or a slap foot. When you're trying to walk, the front of your foot is hitting the ground, or you feel like you can't lift your toes up and you keep stubbing your toes in the floor, tripping. So if you have acute weakness such as that, I'll definitely, as long as the MRI fits and, the nerve is being compressed, I'll send those patients over to a surgeon sooner, because there's true weakness, and you want to make sure that doesn't progress or become something that can't be corrected. And then obviously we always talk about, any loss of bowel or bladder control. Are you peeing or pooping yourself and you don't even realize it? Or, if you
Not
go to,
good.
not
Not good.
good. No.
Yeah.
There is a difference. You will, a lot of times, patients who have like spine related issues in the low back, they'll describe like a urinary urgency, like when they have to go, they have to go. It's hard to
Hmm.
hold it,
Yeah.
but they know they might have little accidents because they can't get to the bathroom quick enough, but they know they have to go. They don't have that type of issue with the bowels, and when they wipe themselves, they can feel their genitals. That's different. I do
Yeah.
see that a lot. I mean, would you agree with that?
Yeah, I
Do you
mean,
see
I'm
that?
in a geriatric population mostly, so I hear a lot of pre-existing urinary incontinence that is
Hmm.
probably isn't related to the spine condition. So sometimes that's hard to tease out. So like you said, I always kind of go to that. Okay, well, do you have control of it? Can you feel it coming out when it comes out, or are you just going and not even realizing it? And uh, only a couple times have I had someone say that, and that's way more concerning than I think kind of the urgency that you're talking about. A lot of people have urgency related to other issues like prostate issues, or for women, the kind of the a lot of women can get urge incontinence or stress incontinence where they cough and it comes out, and so especially as they get older. So kind of take that with a grain of salt unless it's kind of really new and really progressing.
Hmm.
Yeah.
Yeah. And I think with acute disc herniations, even large disc herniations, those like worrisome symptoms are pretty rare. Even the weakness, you might feel a little weak because the pain, but you examine patients, or you could have them do some functional testing, which we can do, through face-to-face video conferencing. You can tell that, they still have their strength.
Right.
They might feel a little weak because of the pain, but overall, it's not something that's an urgent issue.
And if it's not really bad, I think we know that most people will get a little bit of strength back over time. So if you have a little bit of weakness that's really only detectable through kind of fatiguing the muscle or through a good examination by, your physician, that type of weakness most often will come back with time. If it's more severe, like you said, that would be kind of more concerning that the nerve is more affected and
Yeah.
may need to be treated sooner rather than later. And that's kind of how I approach it. If there's a little bit of weakness, I'll say, look, you're a little weak here. Usually that will come back. Um, if if you want it to maybe be more likely to come back, you should get surgery sooner rather than later. But there's a good chance it's going to come back, and with time, and you probably don't need surgery. The main concern would be if it progresses or gets worse, then we would
Mhm.
want to get you to surgery. That's kind of what I tend to say.
So say still on disc herniation, patient hasn't seen a surgeon yet, treating, I would guess maybe a little younger of a patient, but treating, is doing PT, may or may not have had an epidural yet. Symptoms are getting better, but they're still functionally limited and interferes with their quality of life. Say it's been 4 months, I mean, and they want to see a surgeon or ask you about a surgeon, or what's your opinion as far as the timeline there?
I mean, my opinion is to always kind of, if you're willing to, exhaust conservative care options, and conservative meaning like non-surgical. So to me, that's physical therapy, some medications for a disc herniation with pain in the leg, an epidural steroid injection. Um, and I would tend to recommend all those things prior to considering a surgery. Um, I don't always say, I wouldn't always stop a patient from trying to go see a surgeon, but because sometimes it's a good idea to maybe just get on the surgeon's radar. If they're considering it as an option, maybe get in there, make sure you have kind of everything you need if you want to get the surgery. But prior to getting the surgery, I would tend to always recommend exhausting those less invasive options if they're available to the patient. And tend to recommend, um, depending on the case, some of them are pretty straightforward, but a lot of times it's always good to get a second opinion before you go to a surgery. Just because, just like any physicians, two surgeons might have differing opinions about what exactly needs to be done. And so if those opinions match up, that's a good sign that, it's pretty straightforward and maybe can easily be dealt with. So that would be the other thing I would always caution.
Yeah, and I don't think there's any studies on this, but my kind of rule of thumb, if you have patients who has the disc herniation, has directional preference. Again, we've talked about this before. For instance, they can't sit, but they could stand fairly reasonable, but it still interferes with things. I'd like to see those patients give it at least 6 months, if they can be patient enough
Mm-hmm.
to, and if most people, you'll start to see a change. You might not be symptoms might not be completely resolved, but you should probably see a pretty good change within the first 6 months with appropriate conservative care.
Yeah.
In those cases, if my patients are seeing significant improvement, they still can find positions of comfort and they know what bothers them. If they're willing to keep holding off and working with it and giving it more time, I'll support that. On the other hand, if it's at 6 months, they're doing things and it's working, but pain just still interferes too much, or they're kind of emotionally, it's taken a toll on them, because we can't understate the toll it takes on you mentally as well, because
Yeah.
it's a roller coaster, especially when you're not used to something like that, and it changes every aspect of your life. You're thinking about it from the time you wake up to the time you go to bed, so it can become emotionally exhausting as well. So if we've done appropriate conservative measures and it's 6 months um, into it, and they're still just can't do what they need to do, or they just can't take the pain anymore. I mean, I think that's an appropriate time to see a surgeon. Some people might say, "Oh, well, what about the nerve? Are you putting them at higher risk of chronic nerve pain?" I personally don't think so. Again, I don't think there's any good studies, but if you have a directional preference and there's periods of time where you have less pain, especially with standing or certain activities, whether it be extension based, prone press ups, things like that, and you do fairly well. I think the nerve's telling us that I think it's relatively healthy still, and it's more of an inflammatory and type response. I don't know your thoughts on that.
Yeah. I mean, I think, we could go back to what I said before about, that's probably in the time period where a lot of those patients who are going to get surgery have already kind of self-selected themselves out to get surgery. Like
Mm.
a very type A personality is not going to accept that kind of pain for 4 to 6 months, you know? So, the people who are sticking with you through that time period, you know, they're probably managing a bit better and maybe a lot of times scared of surgery or maybe less of a candidate for surgery based on other medical comorbidities that they might have. So, um, you know, I generally my approach is to offer all the options and then tell the patient, you know, I think that we can get you better with these more conservative options, and it may take time, but with time and with these conservative options, you're very likely to improve. And if you can, you know, sometimes just wait, you're going to get better. And I've had some patients, not the exact same issue, but I've had some patients who just weren't even surgical candidates, and I recommended they go get surgery. They couldn't get surgery, and you know the body heals itself. It's pretty powerful. So you know it just takes time. It takes patience, but you know if you're suffering in pain from one of these things and don't have a severe neurologic deficit, you probably will get better from at least this condition. You know, and like you said, if they have a directional preference, for sure. You know.
Yeah. Yeah, I mean, again, if they have just severe nerve pain, you can't find a directional preference, you've tried things and you're 3 to 4 or 5 months into things, well, then those patients I'll send to a surgeon sooner as well.
Yeah.
I mean, for the most part, you do well with surgery for a disc herniation, right?
Right.
Now, they'll probably remove part of the disc sometimes, depending. They might even do partial laminectomy to decompress the area. But overall, you do well. And I always try to explain to patients, I'm not really thinking, or I guess I always picture it long term, right? So it's not like anytime you have a spine issue, the spine issues kind of stick with you. That doesn't mean you can't do everything you want to or enjoy life for years to come, but it's different than a shoulder, a knee, an elbow. Um, and especially the younger of age you have a spine surgery, the more likely you are to have more. And that's not a fault of a surgeon. It's just normal biomechanics. And it just kind of highlights how complex the spine is, as well as the biomechanical forces that the spine has to undergo every day or withstand. So
Right.
the younger you are, you're going to have the higher risk of having additional surgery. Each subsequent spine surgery, success rates do drop some. Again, doesn't matter. You go to the best surgeon in the world. And at some point, either the second, third, or heaven forbid, fourth surgery, you're going to end up with hardware in your back. And then that's a game changer. All bets are off. Again, you have to sometimes, you have no option. But if you kind of think back, sometimes those chain of events get set off when they could have been prevented. Um,
Yeah.
or you could have avoided having surgery at 30 and you needed it at 45 or 50.
Yeah.
You,
And you
you
know the
bought
other
yourself time.
yeah, the other thing is, you know, every medical treatment we offer has possible complications. So, like, what are the possible complications of physical therapy? Well, they're very minimal. You know, typically, what your pain might be worse for like a day, but, you know, very rarely is physical therapy going to cause any kind of long term deficit or long term kind of issue. Medications. Medications can all have side effects. Pain medications very frequently have side effects. But again, if you have a side effect, we can just stop the medication and the side effect tends to go away. Injections can have adverse events that happen. They're not very likely, and probably the most likely ones are probably not too much of a problem, but you can have an adverse event from an epidural steroid injection, like we talked about. But what is probably more likely to have an adverse event is a surgery. And so, and lots of people can do very well from these surgeries, but if you become one of these people who then you form some scar tissue around the nerve, and then the nerve is kind of always being squeezed by the scar tissue, and then you develop chronic pain down your leg, sometimes there's less uh, good treatments for these complications that can arise from a surgery. The other thing that happens a lot of times after like a discectomy, like you're talking about, is a reherniation of a disc. So if you go right back into your old ways of movement, you can herniate right through that area where they previously removed the disc and get the same problem again. And there's other things, anytime you're cut open, you can have an infection or things like that, and they're low likelihood, but the likelihood is not zero of these things. And so that's just another reason why I prefer to be as conservative as possible. If I don't think I need to do an injection for someone, I'll recommend they don't have an injection, and just stick with the physical therapy and some medications that work. And that's just one of the reasons why I always try to keep people from having surgery if it's reasonable, and if we can keep them away from it, because if they get one of those other complications, I just think that's highly unfortunate.
Yeah, and like you said, you remove enough disc, especially if you're young enough, you're going to accelerate arthritic changes uh, in the facet joints, which we talked about. That can predispose you then to developing stenosis at a younger age. So again, you have to think all about these things as well. And I would agree with you. When I'm seeing a patient, I'm not recommending an epidural 2 days after a disc herniation either. We're getting them into therapy. Typically, I'll try to wait 2 or 3 months. Every case is a little different. There are some times where, yeah, we do epidurals much sooner than that. But I want to make sure patients have a foundation for kind of manual medicine approach as well. So,
Right.
we want to hold the surgeons to a high standard, not to jump the gun, but we should also, hold ourselves and in our profession to high standards too. Just because we can do an epidural doesn't mean we should on everybody right away as well.
Right.
Um, yeah, another very common reason to have surgery in the lumbar spine is obviously spinal stenosis, right? So, and you see a lot of this, I'm sure, where
Mm-hmm.
you're at. So,
Definitely.
I guess when you're seeing patients, when do you recommend someone to see a surgeon? What kind of symptoms are you looking for? What are you looking for on the MRI? That kind of thing.
So, right off the bat, if it's the first time I'm seeing someone, the things we talked about, bowel bladder incontinence, or really significant weakness in the legs related to some lesion that we know is in the spine, probably causing this. That's a concern kind of at first sight. Um, then, if none of those major red flag signs are there, then I'll tend to take them through the same treatments that we talked about for disc herniation, physical therapy, medication trials, injection trials, to try to prevent them from needing to have a surgery. The only times where I've sent people to a surgeon kind of sooner is really if the pain is really, really severe and really intractable to the point where they can't even like stand up or lay in a bed comfortably. I have some people who have some just really severe exacerbations, um, and I've recommended some of them to go to surgeons, and that's the same group where a couple of them just couldn't even get a surgery because of all their medical problems, and they do end up getting better, but they're miserable for months at a time, really. Um, and there's a few of those people that every time I see them on the schedule, I'm worried that they're going to come back in and be as bad as they were before, because there was just nothing I could do for them except give them really strong pain medication and just tell them to relax for months, because nothing else worked. So those people I might send to a surgeon sooner rather than later. And then the other people tends to be the chronic spinal stenosis with kind of ongoing claudication that just doesn't really get better with anything. So claudication being pain with walking. And when you have spinal stenosis, the canal in your spine where the nerves travel gets smaller when you stand up for pretty much everybody. And so what happens is the nerves get squeezed when you're standing and walking. It gives you pain and cramping and maybe some numbness in the legs. And then as soon as you sit down or kind of bend over, the symptoms will kind of resolve. But some people have it really severe where they can't even walk a block or a half block and the symptoms come on. And it doesn't necessarily, the pain's not so terrible, but they just can't function well because it's just so limiting to them. And so those people tend to take some time to get to surgery. We'll try some medications, we'll try some therapy, we'll try some injections. They tend to come back and say, I'm doing okay, but I'm not great. And after like a handful of visits, they'll be like, all right, I'll consider the surgery. And then, some of these people get surgery and they do great after a surgery because as soon as they have that decompression of the canal, they can walk, and like they could probably 10 years before, and they feel great again. But without any of the red flag signs, I certainly don't push people to surgery who don't want surgery. But, if I'm not finding results with the treatments I'm offering, it's certainly an option. And it definitely helps when you have a clear lesion on the MRI and they get that decompressed. It certainly works very well.
Yeah, I feel like some of my spinal stenosis patients who typically are older in age, I'm usually trying to convince them to see the surgeon.
Right.
Especially if, we've exhausted all conservative care because
Right.
stenosis is tough. Epidurals don't work as well for spinal stenosis. It's more 50-50. But, a lot of older patients too just, don't want surgery, or they've seen a lot of different various outcomes, or know somebody that's had some type of surgery and had this type of outcome. But so yeah, I'm often trying to at least have them talk with a surgeon because,
Yeah.
like you said, if it's central canal stenosis and it's one or two levels, and there's no listhesis or slippage of the bone on top of each other or dynamic instability, usually they do pretty darn well.
Right.
The tricky part, and I'd like to get your input on this. I see patients, right? One of the reasons to get stenosis is arthritis and from the facet joints, which we've talked about. So those like thick little knuckles in the back part of the spine, they'll cause narrowing in the center of the canal, but they'll also cause narrowing where the nerves exit the spine. So you'll have both central canal and neuroforaminal stenosis. Those sometimes are a little tricky. And surgeons can easily decompress the center of the spine, right? They remove the lamina. Where the nerves exit becomes a little tougher, right? They could do a little rotor-rooter job where the nerves exit. They can't open it all the way up because then they could, what we call, destabilize the spine. You take away too much bone, then the spine's not stable and you need hardware. So some of my patients, especially like the unilateral, so like maybe they have stenosis, but symptoms are all in one leg, right? It's exertional, but it only goes down one leg. And they have bad central stenosis, but they also have really bad foraminal stenosis. Sometimes those cases are a little tougher. I might talk to the surgeon and just make sure they see the same thing I see and we're thinking along the same lines. Because sometimes those cases, sometimes they come back and they still have symptoms, and I think it's more kind of from the foraminal narrowing.
Yeah.
I don't know your thoughts or.
I mean, I see a lot of spinal stenosis, and I would say that I tend to focus more on the central canal stenosis because when I see like most patients with central canal stenosis, a lot of them really only have one-sided symptoms, and I don't notice any difference in the foraminal stenosis. So I would, and I don't know why that is exactly. And really only one level, so maybe they have the stenosis at L3, L4 level, but they only have symptoms going down the back of their leg. And that would be more of the S1 nerve for patients out there. And that's a little bit lower down where that comes out of the spine, but it could be being compressed at the L3-4 level. And and there's other nerves being compressed there, but for some reason we're not seeing symptoms related to that. But I tend to focus on the central canal stenosis unless that foraminal stenosis is like really like severe, obliterating the foramen where the nerve comes out. Um, and because the other thing we can think about is, maybe they did develop the symptoms only because there's like kind of a double injury, like a double crush injury to the nerve, is what we would call that. So it's being squeezed in the canal and then also in the foramen. And maybe if you just relieve one of the areas of compression, maybe they get better after that. So I haven't seen too much where I've sent patients for surgery and then they came back and they still had foraminal stenosis and still had pain. But it's definitely possible. I definitely look for it, but I tend to focus more on the central canal, I think. And I think it seems to cause more of an issue because also I would say that you see a lot of foraminal stenosis on MRIs that doesn't cause any symptoms at all.
Hmm.
And I would say that I probably see less central canal stenosis that is like totally asymptomatic at all times. So I don't know if it could just be my opinion and how I see things, um, but you see so much foraminal stenosis kind of all over the lumbar spine when you do an MRI, and so frequently it has nothing to do with anything. And so I tend to focus more on that central canal. And um, yeah, I haven't seen anyone come back, but we're talking about sending patients to surgery. I probably send less than 5 patients a year for spine surgery. Like
Uh,
I could count them on one hand, I think. And I think that's a product of the patient population I have is, a lot of them don't want spine surgery, even if it's an option. And then a lot of them aren't candidates. And so that really narrows it down to not too many people. But I'm really not sending a lot of people for surgery that are actually getting surgery done.
gotcha.
Yeah.
Gotcha. Um, I think what it comes down to, if patients are seeing a surgeon as one of the first physicians and they're recommending surgery, I think it's reasonable to get a second opinion. Even if the surgeon's well respected, you like him, you get along with him or her, you feel comfortable with them, I would always recommend a second opinion. If you are following with a non-operative spine specialist, such as a physiatrist or a pain physician who trained in physical medicine rehabilitation, and um, you know you trust them, you have a good rapport, they're very competent, and they send you to a surgeon. If it's kind of straightforward, clear cut, then you can kind of make a decision. If there's any discrepancy between what the docs might be thinking, that's where a second opinion would be useful. Um, and yeah, you just have to think about the long term, consequences. There's uh, always long term consequences to everything we do. Spine surgery is very complex. It helps a lot of people and it's needed for a lot of people, but it's not something you want to jump into. So, because like you said, once you have a surgery, and then if you have recurrent pain, it becomes that much more difficult to treat.
Yeah, definitely. Definitely. Those are some of the toughest patients to treat.
Yeah, yeah, and then you start talking about, in my opinion, I don't know what you think, epidurals in for pain that's coming from post-operative sites, or, if they had surgery at L4-5 or 5-1 and they're still having L5, symptoms, epidurals, I don't really think do too much in that case.
Yeah. Yeah. I haven't seen them do a lot for those patients. I think that's maybe more where then you end up getting a spinal cord stimulator implanted, and you've got a whole nother piece of metal in your body now. And once you get another piece of metal in your body, then you can't ever get an MRI again, and all these different things. So I always think it's best to be as conservative as possible if you can get better that way. Some people can't get better that way. Some people don't have the time and patience to get better that way. But that's the approach kind of I always take.
I always tell patients, when you do talk with a surgeon, you want to ask them what's success rate, what's failure rate. You want to make sure they know what your most bothersome symptom is, right?
Yeah.
So spine surgery, as we've alluded to before, but we didn't directly mention today, is a lot better for radicular pain or for extremity pain, right? Pain in the leg. Not as good.
Sciatica.
Sciatica.
A lot of patients would refer to it as sciatica.
It's not as good for just pure back pain, right? So I see some patients where, they have a component of sciatica, but their back pain's the most bothersome, right? So if that's the case, well, spine surgery might not be the best option for you, or you just want to know going into it that there's a 50-50 chance your back pain still is going to be there. And these are questions, or these are things you want to make sure the surgeon's aware of too, right? Because it's not just surgeons. I think most physicians, right, especially the hustle and bustle of a normal day, you see a patient, they have sciatica, the MRI kind of fits with it. Oh yeah, we can help that. But then, sit down, really talk, tease things out. Oh, okay, you have sciatica, but it's more the back pain that bothers you. Well, that's kind of a different conversation. So
yeah, my wife's friend just had back surgery for chronic back pain, and the surgeon told her that she had a greater than 80% chance of 100% relief of her pain. And my wife told me this before she got the surgery, and I was like, that's interesting. Well, I guess they really think they know what's going on, and they think they're going to fix it, but that's not what I would expect. And she had surgery. She's slowly improving, but I don't think she hit that 80% likelihood of getting 100% relief. But it's tough. So you have to be wary. That's anecdotal. It's one patient, but you gotta watch out. If a surgeon tells you that that's for back pain, that's pretty confident, and that would be a sign to maybe just get someone else's opinion about that.
Yeah, well, I mean, if you're having surgery, if you're having back surgery for back pain, you're either getting a fusion or a disc replacement, right? I'm assuming she had one of those two things.
Anterior and posterior fusion.
Yeah. And those we didn't even talk about that today, but we've alluded to it before.
Yeah, we talked about it before. I think,
once you have a fusion, that's a game changer.
Right. Right.
So I mean, so surgery for back pain becomes much more complicated.
Right.
So, but well, hopefully she does well. So,
yeah.
Anything else you think our listeners need to hear before we sign off here tonight?
No, I think that's pretty good. If you have questions about if someone's recommending surgery and you're not sure, feel free to contact us. And that's something that we hope we can help people with, help them kind of navigate the progression of care. All right.
Yeah, without a doubt, we're here for you. So need anything, you could check us out on our Facebook page, website, Instagram, or leave comments in the podcast or any of those other sites. So everybody, Happy New Year, and have a good evening.